in people is by vaccinating dogs. We therefore urge the South African community to have your dogs and cats vaccinated against rabies. Furthermore, if you or your loved ones are bitten or scratched by an animal that behaved out of the ordinary or strangely, then you should immediately thoroughly wash the wound with lots of soap and water, then go to your nearest health facility for an assessment and treatment. We also urge you to prevent stray animals from entering your neighborhood by ensuring that all domestic waste is properly disposed of, and do not befriend or feed stray animals. Rather, report these stray animals to your local welfare organization or state veterinary office so that they can provide assistance to you and the stray animals as well. A joint call to the World Health Organization, the World Organization for Animal Health, the Food and Agriculture Organization of the United Nations, is urging governments around the globe to prioritize dog rabies control, and in doing so, to eliminate human rabies by 2030. It is imperative that solutions for the current problems in rabies control in South Africa be actively sought if the country is going to heed this call. However, we acknowledge that we cannot succeed without the full cooperation and support of our communities. With this year's theme for World Rabies Day, all for one, one alcohol, the South African community to take up the call and to end the suffering and death from this dreadful disease, which is totally preventable. Thank you.
Thanks very much, Wayne. I think you've really captured the key points. I'm going to move over to Alicia now, and hopefully you can share your slides. Alicia is the key person in the National Rabies Advisory Group, and she's a Dalrid and is a great rabies champion. Thanks very much, Alicia.
Thank you, Lucille. Just to confirm if you can see my screen.
Yes, we can hear you and we can see you. Thanks very much.
Okay, thanks a lot. Okay, thank you, and good morning to everyone that made the time and effort to join the rabies webinar today. I think we're looking forward to sharing information with you. And yeah, please feel free to post any questions or concerns in the chat box. We'll be happy to answer any questions. So just some opening remarks from the National Department of Agriculture, Land Reform and Rural Development side. Mr. Wayne Ramkrishna gave a proper introduction to World Rabies Day and what our aims are in terms of rabies control and also rabies awareness. Probably one of the big questions that everyone should ask is, why should I care about rabies? The big reason why we're conducting so much awareness and doing so much effort to try and curb and contain this disease is the fact that rabies kills humans and animals in South Africa. This is not an exotic disease. It's not something that's foreign to us. It's on our home ground. The problem with this disease is once clinical signs of the disease is present, whether it's in an animal or a human, there is no cure and the patient will die. This just shows us how important it is to prevent this disease. Even though it's almost 100% fatal, it is fully preventable. Then just a quick word on dogs in society, and I would just like to acknowledge Mr. Kevin Leroux. I borrowed some slides from him. He'll be giving you a talk a bit later on in the agenda. So just to make the point that in South Africa, we keep dogs. We live with dogs. We love our animals. Even households that don't own their own dogs or cats definitely are in contact with these animals. It's pretty much part of every child and most adults' life, either through your own animals, your friends, your family, or even dogs and cats walking around in the street. And also pets are a really important part of our households and society. And also the role and the needs of pets have changed over times. Obviously, there's a big role that they play in companionship and also when it comes to security. And just from the pictures you can see below, there's really a special bond between humans and animals. And this is also something that we need to promote and foster. Responsible pet ownership, people taking care of their animals and making sure that they're healthy, and especially with dogs and cats, that they're vaccinated against rabies, keeping the dogs and the cats safe, and even more importantly, keeping the human owners safe as well. We'll be talking a bit more, I think Kevin will cover this as well, regarding the national rabies strategy that we've got for South Africa. I've provided you the link as well if you would like to access this document of ours. This is just basically the strategy that we as South Africa want to follow to eliminate dog-mediated human rabies from South Africa by the year 2030. Obviously, this is a collaborative effort between numerous stakeholders, with the main drivers being the Department of Agriculture and the Department of Health. We've been working together really well on the ground, at local, provincial, and national level. And yeah, the officials that are working with us are really doing a fantastic job. So basically, the message from this document and this strategy is that given adequate resources and political support, our country definitely has got the knowledge and the practical experience to eliminate dog-mediated human rabies deaths by the year 2030. So this is a fully achievable goal. And then just a closing remark, just so that we can remember why we're here, why we're conducting awareness, and why we want to control this disease, is it's literally this easy for a child or for a human to pick up rabies. If you just pick up the wrong animal at the wrong time that's not vaccinated and that's got rabies, that is literally a risk that you're taking with your life. So if we can aim at responsible pet ownership, teaching children how to read animals that are behaving strangely and how to avoid them, and if we make sure that we vaccinate our dogs and cats, we can protect our children, our families, and our communities from this deadly disease. Thanks.
Thanks very much, Alicia. I think you've captured the key points and very much the One Health component, and also, you know, interventions that are not resource intensive, responsible animal ownership, which is something that's neglected. So I'm going to call now on Kevin LaRue. Kevin has been working in rabies for ever since I've been around, so that's a very long time. He's been in veterinary services for 32 years in KZN, and he's our go-to person when I need information on rabies and whether something's a risk. He's an animal health technician. He's also the chair of the South African Rabies Advisory Group. He's been very key with Alicia and Wayne in setting up the rabies going forward for us towards elimination. And he did a wonderful study, operational study really, in KZN through the Bill and Melinda Gates Foundation, showing that if you vaccinate dogs, you can reduce human fatalities. So it's about getting vaccines into dogs, and it has a major effect on what we see on the human side. So over to you, Kevin. Thanks very much.
Good morning, Lucille and everybody else. Can you hear me?
Yes, we can hear you, and we can see your slides. Yeah, all good.
Awesome. Thank you very much. So good morning, everybody, on this wonderful sunny spring day here in KwaZulu-Natal. I'm just wanting to share where we are currently in South Africa with animal rabies and human rabies, so that we can all have a picture in our minds where and what we have to do, and understand our role. So the good news for World Rabies Day is that the graph of South Africa's rabies is looking absolutely wonderful. Obviously in 2021, we had an epidemic of the disease, mostly focused down in the southern part, in the Eastern Cape, in Nelson Mandela Bay area, also KwaZulu-Natal, eThekwini. Major outbreak like we've never seen before, and hope we will never see again. And since then, we've had a battle, but it's been a winning battle to get back to sort of 2020, 2019 levels. Now, while this is quite a spectacular decrease, and there's a lot of people that have done incredible work to get to this, the levels of 2019 and before that are not good levels. So we're back to a position of, let's put it this way, of hope. And the hard work starts now to actually make sure that this decreases even more. We have seen through this outbreak, we've seen amazing collaborations, and we've seen some private partnerships developed to give us a new weapon in our arsenal to control the disease, how we can share the responsibility with the state and the private practitioners. We've seen individuals do some amazing work in very difficult circumstances, but the hard work is now, and we're back to where we were, and I think we need to understand that. So this is just to show that the Eastern Cape and KwaZulu-Natal, they represent 70, I think it's 74% of all samples submitted in South Africa. So these two provinces dictate what South Africa's rabies looks like. They also, within those provinces, there's 84% of the positive cases. So the country's figures are skewed by these two areas where the mass of the samples come in. And a year ago, actually, the samples from the Eastern Cape was even more than KZN, record samples, numbers of samples over the last 2 years. So it is skewed, and it's then difficult to say, is the disease decreasing in all provinces equally when these two provinces have such a significant impact. Just to show you what has happened in those two provinces, first of all, the Eastern Cape there in pink, absolute heroic effort to have this beautiful declining graph of rabies, mostly centered again in the city of Nelson Mandela Bay and Buffalo City, where the bulk of the work is being done. And then KwaZulu-Natal, the successes have been in two districts, the eThekwini, the big city of Durban, where there's 4 million people, where there's been a decline there, and as well as a decline in another major district. So those two areas of South Africa are affecting the graph, showing that we're having a decline. But again, we cannot rest easy and say this is looking good, where we can kind of stop our efforts now. Actually, we're only just getting back to where we were, and we actually have to double our efforts now to understand where rabies is in South Africa and how and why people die. 99% or even more of that of people that die in South Africa die from bites from dogs. And so the areas where dog rabies is endemic is the areas that we have to focus our attention. It doesn't mean that anywhere else in South Africa is safe. Anybody can be bitten by anything, anywhere in South Africa. We've got to remember that. And you can never be complacent about the most deadly disease known to man. But if we, and as Alicia has told us about the strategy going forward, if we look to how can we control this disease in South Africa, we are looking at these areas marked on the map here in yellow, the yellow circles. This is where dog rabies is endemic, where it's flourishing. And should we vaccinate parts of these areas, we can actually stop the disease completely. This has been shown in many places in South Africa that you can have a massive impact on dog rabies in a relatively short time. And by doing that, you can stop human deaths. This is a universal truth. It's a global truth. And we have demonstrated. So for those doubters that say maybe we can never get on top of this disease, we've already done it, and we've already shown how to do it. And so we know what to do and where to do it. So if we're looking to the future for 0 by 30, and we look at that little map in the top right-hand corner, there's only 3 places in South Africa at the moment where people die of dog-mediated rabies. And that's Limpopo, KwaZulu-Natal, and the Eastern Cape. And within those areas, as you can see from the map, sorry that the boundaries for the other provinces are not clearly marked, but there's specific areas where the disease flourishes. It's because of the community types, perfect conditions for dogs to move and bite and the disease to exist. And even within those areas, there are sub-areas, which are source areas. So in the Eastern Cape, for example, while we see big outbreaks in the cities, And that's another debate about poor vaccinations and migrations of people. The actual source for the Eastern Cape is the former Transkei area. So if we wanting to really control the disease there, we need to focus in those areas. In KwaZulu-Natal, also, we have a lot of good infrastructure in eThekwini, so we have a lot of cases there. But the disease often has its sources in vast rural areas. The same with Limpopo province as well, vast rural communal areas where the disease flourishes. And these are areas where the services are poor. So the way in which South Africa is going to contain rabies and stop human deaths is by focusing their attention on these areas. And according to the broader size and scale of South Africa, these are relatively small areas. And if the country could put its efforts and its combined forces together in these areas, we could actually stop this disease. KwaZulu-Natal was maybe one of the best examples because it was an entire province that was vaccinated. 640,000 dogs vaccinated. That was done in 1 year. And as a result of that, the disease dropped by 93%, and we stopped all human deaths for 2 years. This has been duplicated maybe in a slightly smaller way, but even more effective in Mpumalanga province, where we haven't even had animal cases recently, no human deaths there anymore, where there used to be quite a lot. And in the cities of Nelson Mandela Bay, we've seen a massive decrease. So there's a lot of examples of how this can be done. And we don't have to vaccinate the entire country. We have to put our efforts into relatively small areas. So in order to achieve 0 by 30, we have the success stories. Even Gauteng provinces had outbreaks, and they've managed to repel those outbreaks. So there's many, many examples of what to do. We have the national strategy that Alicia spoke of. We have a national strategy that talks to how we can control the disease, what areas need to be targeted, what is needed in those areas. Each province has its own strategies, and in some areas we have even district strategies of what to do. So taking the combined knowledge of what has happened in South Africa, we can actually control this. We have most things in place to control rabies in South Africa. We have an excellent scientific foundation. There's probably a lot of our scientists on board today, incredible people who have done amazing scientific research into rabies in South Africa. And we have a very good idea of what is going on, how the disease moves, and how we can stop it. And also, we have the tools necessary. We have excellent vaccines with new vaccines coming onto the market, thermostable vaccines that can stop this disease. We've used them before. We have all of the basic tools to do what we have to do to stop the disease. So why is it not happening? I think this is the big question. And it's a question that the world asks as well. So what are the challenges in South Africa? So just as an example, right now, procurement is a challenge. And this is not about money. Right now, we have an administrative failure, could call it that, which means that we cannot purchase vaccines at the moment. We have been distributing because we have a vaccine bank. And so we've been trying to keep up with most of the demands, but that is also running out now. This is a challenge that's almost beyond basic veterinary science. It's the science of implementation that challenges us in terms of getting what we need to do the job. Manpower. The focus for what we have to do is large, well-equipped teams in vast rural areas. And this is more difficult than it sounds. It literally needs to be military-style operations, large scale, in areas where it's difficult to reach, where there's very little accommodation. It's difficult to manage people. You don't have the vehicles necessary to get into all of these rural areas. And so again, implementation, it's about the manpower that we need. And a lot of people these days, a lot of technical people tend towards the cities. It's easy to do vaccinations in a city environment where all the infrastructure is there. It's not easy to do it in the vast rural areas. And those are our focal areas for controlling. Logistics, well, the logistics is linked to procurement, but there are some major financial needs to equip staff. Transport is everything in terms of achieving disease control, getting people to where they need to be, having the correct equipment, loud hailers, etc., and especially supporting awareness. Awareness is the foundation of everything that we do, and that needs quite a lot of financial support to make the communities understand that they need to get their dogs vaccinated and they need to get treated and report problems, etc. In KwaZulu-Natal, one of our main challenges is security. We have a huge hijacking problem, so the teams can't go out and vaccinate. And again, this is kind of beyond the direct control of veterinary services. So it's another huge challenge. If you're going to send out a team, they need security. That requires extra inputs and thought and processes to actually achieve it. But by far, the biggest challenge that we have in South Africa, some people might think that I'm being cheeky by saying this, but it is leadership. The leadership from the presidential level has to make a decision that this disease needs to be stopped. Just about every single death is a health system or a health system failure, which is including veterinary services and all of the services. We all fail communities. And so leadership right from the top needs to come on board to say, we're going to do this. Here's the necessary support. That leadership obviously has to cascade right down to the ability and leadership to manage large-scale operations on the ground. And I have to stop there because that's what it's all about. If you look at other disease control programs like COVID, it's about managing large-scale inputs on the ground. And that's all about leadership at every level, to communicate across all of the different sectors, to bring people together, to motivate people, to organize, to lead, and to put the vaccine into the right places. Rabies control is easy. You vaccinate the dogs, the disease goes away. It's implementing that this is a challenge. And that is true for many aspects in South Africa, veterinary services and health services. The World Rabies Day is an incredible time. Last year, we had such a success. I believe that the decrease in South Africa is partly because of what happened last year, because of millions of people were touched and got information, and a lot of dogs were vaccinated. This is an important day, but rabies is about every single day. So we encourage people every single day to tell your friend, tell your neighbor, tell every social network you have, vaccinate your dogs. It's the only way, and it's the law. Thank you. I don't know if there's going to be any questions.
Thanks. Thanks very much, Kevin. Really inspiring. Ever the optimist, despite all the issues that don't support the science to reach the field. Are there any burning questions? I can have a few minutes. We're ahead of time just for one question, if anybody wants to raise anything. So these operational issues are a continuous problem with many of our public health programs. I mean, how do we manage this?
I wish I
really
knew.
Have to despair.
As I say, we definitely need the political support, because a politician at a high level can make all of the difference. And hopefully today is helping to highlight that. Our MEC is very involved at the moment. And because that decision then often triggers other sectors that will come in and support. But there's a lot of challenges at many levels. But there's so many good stories that come out, and I could just share one. We had an area that was completely inaccessible due to hijacking, and one single animal health technician took it upon herself to drive in there with her private vehicle, have lunch with the chief of the area, develop a relationship with the local leadership, and between her and some local people who were willing to protect her, she managed to vaccinate an entire district, and the disease completely disappeared. So it can take single heroes like that to make the difference. And at a political level, you can make such a difference in rabies so quickly. It is really a low-hanging fruit for a politician to set himself up. A lot can be done with relatively small amount of enthusiasm.
Yeah, it's a really inspiring story. And I think it's an opportunity also to give a shout out and pay tribute to our wonderful animal health technicians and those involved in the campaigns. They really are unsung heroes. So thanks very much. There is a question in the chat. I'm going to keep it till afterwards. It's about cats. We also always talk about dogs, but let's keep that to the end. So thanks very much for that question. I have it noted. We're going to move on now to Pancho Bapela. If you want to put up the bio, I can't seem to manage all these controls, Mr. Ferry. That would be quite nice. So I know Pancho very well. Pancho trained with us in the FET program. Pancho started life as a nurse and is now based in KZN as our NICD provincial epidemiologist. So over to you, Pancho, and let's hear from what's happening on the human side. Thanks very much. Pancho, you're able to share your slides? There we go.
Good morning, management and
we don't see your slides. If you've got, do you have slides?
Yes, I do have slides.
I'm not seeing them. Are others?
Yeah, let me share.
There we go. Perfect. Coming up. Great.
Okay.
Thank you.
You see that. All right. Thank you so much. Unfortunately, due to load shedding, I'm presenting from my car. I had to go seek network somewhere else. Good morning, management and colleagues. I'm going to be taking you through what is happening in KZN. So I will start. I don't know if I have to start here, but I will start by saying, as we all know, that rabies is a viral zoonotic disease which is transmitted from animals to humans, and it spreads to humans and other animals through contact with saliva or tissue of infected animals. And the human infection only happens when the saliva or the soft tissue of a rabid animal enters the membrane or an open wound of a person. And the risk of transmission is known to be low in cases where the skin of the exposed person is intact. So globally, the disease causes approximately 59,000 deaths yearly, which contributes the highest case fatality rate compared to all the other infectious diseases. So it's reported to be the human rabies. It's reported to be killing 1 person every 9 minutes, with 40% of the deaths being children under the age of 15 years. And it's also associated with the loss of estimated 3.7 million disability-adjusted life years, with economic losses of at least $8.6 million. So according to the WHO, rabies is one of the most neglected diseases, and which is severely impacting poor rural communities in low and middle income countries. So in South Africa, the majority of the human exposures are linked to dogs, as the previous speaker has mentioned, with more than 99% of the deaths dog meat are dog mediated, and then the dog bite, the dog mediated human rabies deaths are found most commonly in domestic dogs in KZN, Eastern Cape, Mpumalanga, Free State, and Limpopo provinces. And then, however, from 2019 to 2022, the provinces with the highest burden of human deaths were Eastern Cape, KwaZulu-Natal, and Limpopo. And then since 2021, these provinces have been experiencing an increase in frequency and size of local rabies outbreaks that infect both animals and humans. So as we all know, the disease is incurable, but 100% preventable in both humans and animals. And according to the Animals Act, we need to be vaccinating our animals, and then which is prescribed to be twice in the first year and the booster. And then with the prevention, we have to get appropriate exposure prophylaxis to the animals and those at risk, which is not really happening in our country. And then we have the post-exposure prophylaxis, which is supposed to be given in the given dates, which is day 0, day 3, day 7, and 14. And then we've also immunoglobulin around the wounded area, which is for category 2 and 3. And then since 2019, in 2019, we had 10 people who were laboratory confirmed, and then 4 was from KZN, and then Eastern Cape and Limpopo. And then in 2020, 86% of the cases that were reported were coming from our province, KZN, and the others were from Limpopo. So in addition to those lab confirmed cases in 2020, we had 3 cases that we could not confirm, which were 3 children from one from KZN, the other one from Limpopo, and we had the one from Eastern Cape. And then in 2021, we had 10 cases, and then I think some typing error happened there. So we had 10 cases, and then we had not 10. I think in 2021 we had 19 cases, whereby 9 were from Eastern Cape, and then KwaZulu-Natal 6, and then Limpopo 4. And then there were in 2022 we had 13 confirmed cases with 6 probable cases. However, that was a small decline compared to the 19 cases that we had in 2021. And then in 2023, so far 7 laboratory confirmed cases, and then 2 from KZN. And then going into KZN, we can see 2021 we were hit the hardest by the rabies. You see, we had quite a number of cases in KZN, and then in 2021, and going deeper into these cases, I actually mixed the probable and the confirmed cases, and then you can see in terms of where are we actually receiving more cases. So looking at June and July, that's where we actually in the our province we seeing more and more cases that are confirmed then. However, if we look into the incubation period and all that, we know the case might be exposed today and only develop symptoms in 2 to 3 months, and for, depending on the area of exposure and all that. So these are the districts that have the most number of cases in our province. So we have in eThekwini, Metro, which is actually contributing most of the cases there. And then we have in Ugu and also Kimvejwayo there, and then Ilembe and Umgubundlufu. And then in terms of age distribution, we having mostly the cases on the NMC system, like they were unknown in terms of the age. However, we do have the number of cases, even adults there, and then we have 10 to 14 years. And then when you're looking at the distribution of the cases there, we have 11 cases from 2021. This is from 2021. So these are the districts that actually contributed the cases from 2021 to 2023. eThekwini contributed 58% of the overall cases. And then those are the areas that had those cases in eThekwini district. So now, looking at this, we realized when we were analyzing the cases that most of our cases, they never sought medical attention after exposure, and they did not, then it means they did not receive the post-exposure prophylaxis. And then those who sought medical attention did not follow up for subsequent dosages of the post-exposure prophylaxis. And in some cases did not report a history of dog bites on presentation in healthcare facilities at all. And then the majority of the cases also opted for traditional medicine before and after consulting the healthcare facility. So when the case gets a dog bite, they normally opt to go to traditional healers, and then or else some of them, after consulting the healthcare facilities, they actually go back to continue with their traditional medicine treatment. So the challenges we have been, it's late presentation of these patients. They come already when the symptoms have set, and we already know that once the person has the symptoms, there is nothing we can do. And then the incompletion of the vaccines, and then we also have too many stray dogs in the community, and no one is accountable for them. And then again, dog owners not wanting to vaccinate their dogs. I remember in one of the districts, the reason was that they having the races like for the dogs. So the dogs are racing, having the racing. So if you vaccinate the dog, it loses the momentum or the speed. Like, so now they are going to lose in those kind of races. So that's why some of them, they do not opt to vaccinate their dogs. And then again, we found out there is a problem with delay and no referral from traditional health practitioners to the healthcare facilities. And then we recommend that healthcare workers, they should remain vigilant and conduct thorough history taking, because some of these patients don't mention the dog bites and all that. And then healthcare workers to follow up on cases when appointments are not kept. I think this we need to emphasize on this, because now if we have our clients only or our patients only coming for one dosage and then they never follow up, I think as healthcare workers, we can make it a point that we actually do initiate a following up of these people to make sure that they receive all the vaccinations as prescribed. And then strengthening of surveillance of dog bites in all the districts. In KZN, we do have reports sent on weekly basis to the CDC coordinators of all the dog bites happening in the district. And then health education, including in remote areas, and then also in schools about the importance of prophylaxis after exposure, and development and distribution of posters in the local clinics and community halls. And I think these have to be going down to our remote areas. And then involvement of donors also in campaigns about dog bites and human rabies. And then in our province, the interventions after receiving all the cases, we now training our community health care workers in all the districts. And those community health care workers, they reach out to the communities, and then what they do when they have dog bites and all that, they actually report them to the health facilities. And then we also have engagement with social media platforms, the different platforms. However, I'm not going to dwell on this because there is a follow-up presentation on this. And then again, as part of the intervention, we conducted a study which involved traditional healers in eThekwini district. This was like a KAP study, which we looked at knowledge, attitudes, and referral practice regarding animal bites and prevention of human rabies among traditional healers in eThekwini district. And then these results, we're going to be presenting them to the province and the district. I think we're going to also have to cascade the results to the other districts so that they can learn from what is happening in eThekwini. And then these are the references. Thank you so much, colleagues.
Thanks very much, Pancho. And really some great initiatives in the community. And it would be really good to see your study. I think the involvement of community health workers is a wonderful initiative that we need to employ elsewhere. There are quite a lot of questions in the chat, but I see we are on good time. So post your questions and we'll answer them in due course. So our next speaker is Nazneen Muller. Nazneen works with me at the NICD. She's a senior medical scientist. She works in the Center for Emerging Parasitic and Zoonotic Diseases. And she's the one who works on brain and saliva samples that are submitted on suspected patients. And I have to say, it's really incredibly sad when you have a bottle with a specimen of a child's brain, and it's suspected or confirmed rabies, and you think, well, this could have been prevented. And I think whenever we do have a confirmed case, we must use that opportunity to identify where things have failed, either in the community, on the veterinary side, or in administering post-exposure prophylaxis, to identify things that could be better. So over to you, Nazneen, and we're going to look at the diagnosis of rabies and what specimens to submit. Thanks very much. We don't see. Do you have some slides, Nazneen?
Yeah.
Okay.
Can you
Excellent.
see my slide?
Yes, all good.
Can everybody hear me?
Yes, we can hear you.
Okay, good morning, everybody. And thank you for this opportunity. I've been asked to share some information on laboratory diagnosis of rabies this morning, mostly concentrating on what we require from our side to get a definitive answer in a suspected case of rabies. Oh, sorry. Testing is only indicated when patients have clinical signs and symptoms of rabies. And clinicians with suspected rabies cases can contact the NICD hotline. Please make sure that you have the correct number. The number's changed over the years. I think since COVID, the old number is no longer in use. And so the new number is 0800 212 552. And you can get consultation for suspected clinical cases of rabies on the hotline. As well as direction as to what is required in terms of submitting samples there as well. This information is also available on the NICD website. For cases, a case investigation form that is available, the NICD one, that is also available on the website, must accompany the samples. It's important because it gives us information that about the recent exposure, that we can also direct testing, and we can also direct investigations to other possible exposures in the area as well. So I know it's different from the NMC clinical investigation form, and in an ideal world we should have just one form, but at the moment the two don't speak to each other. So it's really important for us from a lab point of view to have our form completed and accompanying the samples to the lab. Exposure cases, as mentioned, need post-exposure prophylaxis. We cannot test for exposure to rabies. So as soon as a patient presents with a dog bite history and there's a suspected risk of rabies, then post-exposure prophylaxis must come into place, and that is the direction they must be sent to the clinic for a full assessment. Do not take samples and send it to us. We cannot test for exposure to rabies. We can only test for clinical suspected cases. Laboratory testing for rabies includes, so we can test ante-mortem as well as post-mortem. Ante-mortem, the samples that we require are saliva, CSF, or a nuchal biopsy. There's a broad overview that's shown in the slide, but ante-mortem, several tests are often necessary to diagnose rabies. A single test is often not sufficient. We can do a reverse transcriptase PCR is used for detection of the viral RNA, and that is in saliva samples or CSF samples. Because the virus is shed intermittently, we can have a hit and miss scenario ante-mortem, depending on when the sample is collected. It's particularly for saliva. That's why it's important to send more than one sample. The CSF can also be used to detect rabies-specific antibodies, but we recommend that if you have a case ante-mortem, that you send a range of samples so that we can cover the diagnosis more broadly. Post-mortem, the gold standard is to detect rabies using direct fluorescence antigen detection. And this is using a brain biopsy sample. We can also use nuchal biopsy sample if taken soon after the patient passed away. So for sample collection, as I mentioned, when submitting saliva samples, it's important to collect at least 3 samples, and we must collect saliva, not sputum. We need at least 0.5 ml of specimen, and the samples must be taken at different time points so that we cover the intermittent shedding of the virus in the saliva. And so this different time points, if possible, different days. So, or else, for example, you can take one in the morning and then one in the evening and one the following morning and submit those 3 samples. CSF can also be submitted ante-mortem for PCR testing and antibody testing. And again, we need at least 0.5 ml in a sterile tube. For nuchal biopsy sampling, a section of the skin is taken. It must be taken at the nape of the neck, because rabies will be present in the cutaneous nerves at the base of the hair follicles. You can use a punch biopsy, or you can just perform an excision. We need about a 5 to 6 millimeter wide by 5 to 6 millimeter deep sample. It must be placed in a gauze moistened with water or saline. No fixative is required, and these there are rabies guidelines for sample collection available on the NICD website, as well as if you contact us directly, we will send them to you. For post-mortem samples, it's important to get. It is important to get a definitive diagnosis for the suspected clinical case. So, if possible at all, if the patient demises and rabies was suspected, please try to obtain a brain sample and submit it for testing so that we can get a definitive diagnosis. The brain specimen is the preferred specimen. We need a small section of both the cerebellum and the cerebrum. The specimen can be submerged in 50% glycerol saline, or if that's not available, you can freeze it and send it directly. Please do not use any formalin to fix the samples, as that complicates and can lead to false negative testing on the DFA sample. So just either put it in glycerol saline or send it fresh, frozen, as soon as possible. And then samples can be transported to the NICD directly. You can use the NHLS transport network. The samples are sent daily from all the NHLS labs. Please transport the sample on ice and send it as soon as possible. Please remember to include the case investigation form. For more information, you're welcome to contact any of us at the NICD, but all of this information is available on the NICD website. Thanks for listening. If there are any questions, I will take them.
Thanks very much, Nazeem. I think that was very comprehensive. Just one or two points to pick up on your talk is we as you mentioned, we get a lot of bloods for rabies. So virus is not found in the blood, and it absolutely just delays post-exposure prophylaxis, and nobody should ever send a blood to help make that decision about the necessity for post-exposure prophylaxis. It's purely done on the risks and the circumstances. And as you mentioned, we try and call everybody where we get a blood. The big problem on the human side is actually accessing brain specimens. You know, the vets are trained, and it's quite easy to get a specimen of a dog brain, but it's not easy to get a specimen of a human brain after somebody's demised. You need a pathologist generally, so I think we don't always end up diagnosing or confirming the diagnosis. And I think it is important, even if you don't have a confirmed diagnosis, to notify these as suspected or probable cases, because they need to be counted and they need to be investigated. And one last comment, don't wait to take a specimen. Often the patient comes in on a Friday, and people wait till Monday, or they think they'll do it on Monday, take a saliva. You need to do it as soon as the patient comes in. It's an opportunity to try and get an ante-mortem, relatively non-invasive specimen. Often by the time Mondays come, the patient has demised and you've lost that opportunity. So thanks very much. I think we're going to move on now to open to you, over to you, Sharika, for NMC and rabies. Thanks very much. Yeah, we can see the slides. Off you go. Can't hear you.
Okay, good morning, everyone. Can you hear me now?
Yes, we can hear you.
Okay, so I'm going to do the notification of rabies via the Notifiable Medical Conditions electronic surveillance system. So rabies should be notified so that an outbreak response or a response to a specific case can be done. And just as a brief introduction, the National Health Act of 2003 was amended this year, February, and the categories of diseases have been amended, but the notification process remains the same. So in the National Health Act, there's details of the legal requirements for notifiable medical conditions in South Africa, and this is in line with international health regulations. And the details of this is that every doctor or nurse who diagnoses or treats a patient with any notifiable medical condition should notify that patient. The reason for the notification is so that a response can be done to that notifiable medical condition, but so that we also have a database of all our notifiable medical conditions in the country. We have 4 categories of notifiable medical conditions. I'm only going to go through category 1 because rabies is category 1. And your category 1 notifiable medical conditions need an immediate verbal, SMS, or telephonic report on clinical suspicion within 24 hours. So clinical suspicion would mean that you don't actually have a lab confirmation yet. And all of your category 1 conditions have a case definition, and rabies also has a case definition. So if the patient meets the case definition, you can notify this as a category 1 condition. The electronic system can be used to notify this, and this would mean that everyone who needs information on the case would receive it immediately. So as you can see, rabies is category 1, and it's human rabies. So this is the human that has signs and symptoms of rabies. We are not notifying animal bites or dog bites on the NMC system. So if you do have a patient that comes in experiencing a dog bite or an animal bite, and you have to categorize that and give prophylaxis, that's a process that will happen in the clinical field, but that's not something that needs to be notified. The notification happens if a person comes in with signs and symptoms of rabies after exposure to an animal, and you don't wait for the lab confirmation. If you suspect the patient has rabies, you would notify that patient on the NMC system so that a response can happen to that case. And the response happens at a facility level as well as your sub-district or district level. So with the electronic system to notify, it's a real-time notification system. So whatever information gets put into the system is received immediately. It's like sending a WhatsApp message. The person would receive it on the other end. And it's linked to everyone that's on the system, from the facility to the sub-district, district, as well as provincial and national levels. It's direct data entry, so you don't have to fill a form and then capture the form and file the form away. The information that's in the electronic system is accessible. It doesn't expire or go away. You would always have access to that information, and you're also able to edit the information that's on the system. For category 1 conditions like rabies, there will be an SMS and email alert that will get sent out as soon as the information is saved on the system. And this SMS and email alert acts as an early warning system for the focal people that need to act on the case, and that will include environmental health, your facility level, which was your IPCs, as well as your sub-district and district level. So they would know immediately that there is a rabies in your facility, and they would know what actions to take on that. But it's only if you put the notification on the system would the SMS alerts go out, so that the response can happen. All your lab data for notifiable medical conditions are linked from the National Health Laboratory Service to the from the public sector to the NMC system, and there are some of the big private labs that are linked to the system. So if you have suspected rabies and there is a specimen that gets sent to the lab, there would be an SMS alert when you have notified that initial clinical suspicion. And if there is a lab confirmation, there would then be an SMS alert later on with the confirmation that the rabies is lab confirmed. So this is the link to get onto the NICD website, specifically to the notifiable medical conditions surveillance system. On the KZN Health Internet, you can access the system via the internal network. So if you go to the Communicable Disease Control webpage, you have a direct link to the NMC app. And there's also guides on how to register on the system, how to reset your password, notify cases, edit cases, that you would also find on the Communicable Disease Control webpage on the KZN internal network. So this is the landing page of the NMC surveillance system on the web. And if you've never had access to the system before, you can register on the system. You would register yourself. It's self-register that would be verified. You would then be given login details, and you'll be able to log into the system and notify your cases. It's also available on the mobile platform. It's an app from on your mobile devices that you can download from the Play Store for your Android devices, from the Huawei app gallery for Huawei phones, and the iStore for Apple devices. Billing is applicable, get charged for using the app. And it's self-registration, like I said, you can register for yourself. You need an active email account, and you would be able to then get login details via that email account. So this is what the app would look like. It's called NMC Reporting. So on your mobile devices, you would see this green icon of Africa, and you would then download and install the app, and you'd be able to register there. And once you register, you would receive login details. So when you do register, you'd register with all your personal details. That would include your ID number, the province that you're working in, and your email address. You would then link yourself either as a facility-based user or a role-based user. So if you're working in the facility like a medical center, a clinic, a hospital, etc., you would be facility linked. And then if you're at a sub-district, district, or provincial level, you would be role-based, so that you would have access to facilities in your area. But if you're working in just one or two clinics, you would then register as a facility-based user. You would have access to the system, and this is the home page where you would come in and see your cases, or you would be able to capture a new case. And you would capture a new case of rabies as soon as you clinically suspect that you have a case of rabies. Because rabies is category 1, if any of the suspected rabies, there is a hospital form that needs to be completed on the system. So there was a COVID-19 or a dead cough form previously that is now extended to all category 1 notifiable medical conditions. It's only available as a web-based form, not on the mobile app, but we do have a paper-based form that you can access via the NMC web page. The hospital form will only open when the admission status is selected as inpatient, discharged, or transferred. So it's inactive for outpatients. So this is for hospital-based users who have a suspected or confirmed rabies patient that was admitted in hospital, where we would need hospital details on the NMC system. Previously, the GW17/5 form was used. It's obsolete and is not in use anymore. So it's not being used to notify any condition, and we also don't use it to report dog bite. Access to the electronic system, you would then use the NMC form. This is the NMC form, and you would send the form to the surveillance report email or fax number, which is at the bottom of the form or on the front of the NMC booklet. You'd also send it to your local CDC, that's your district CDC office. The reason you're sending it to both is because when you're using the paper-based platform, there is a delay in getting the information onto the electronic system, and there will therefore then be a delay in the SMS alerts. So the response that has to happen to the rabies case needs to happen fairly quickly. And so if you're sending a paper-based form, there is going to be a delay. So send it to your district CDC as well, so that they would have information and they can then do the response that they need to do. So when it comes to your health establishment level, this is actually from your primary health care or your medical center or your GPs up to your hospitals. All doctors and nurses must report rabies as a category 1 within 24 hours of clinically diagnosing or suspecting the case. And then category 2 gets reported within 7 days. So at the health establishment level, the NMC focal person should ensure that there's upward reporting of cases to the next level. However, if you're using the NMC electronic system, this is an automatic process that will happen. Once you put information into the system, everyone at every level will have access to that information. And the SMS alerts would go out and the response would then happen to the case. I thank you, and I would take questions if there are any.
Thanks very much, Sharika. Put your questions into the Q&A. And yeah, I think it's just to highlight the importance of the NMC for all notifiable conditions. You can really only manage what you measure. And if we don't have these notifications, you know, we're not going to be able to follow up correctly on the cases. Just one question. What happens if the diagnosis is not confirmed, patient has an alternative diagnosis and it's already been logged? Is that the center at NICD's responsibility to change, or who does that? Because a number of suspected cases turn out to be something else.
Yes, so it is the center. Hi, can you hear me?
Yes.
Yes,
Yeah.
okay. So it is the responsibility of the center. They also have that sort of access where they would be able to change the classification. So they would then discard the case if it's proven to not be rabies. If it was incorrectly identified, so sometimes we do get the dog bites that get notified as rabies. That would also then get removed from the system. So
Yeah.
those cases that are incorrectly notified get removed. But if you had a suspected rabies and it was tested and it's not confirmed to be rabies, that classification will change to be discarded.
Okay. I
So
think
the
that would
center
have to
at
be after a
NICD would be-
review, because knowing that some of
Yes.
the tests are, you know, not 100% sensitive unless you get a post-mortem specimen. So I think it's about a review.
Yes.
Okay, so that's the center at NICD. Thanks very much. And the other
Yes.
just clarification is that dog bites are not notifiable. They are reportable, but that seems to be very much a provincial prerogative. And the reason, you know, there are reporters is so that if you see a trend and there's an increase in dog bites in a certain area, state vets could investigate, but it obviously requires quite a lot of resources. So it's not done everywhere. But that's also under review and looking at the value, and maybe we should be introducing that in high-risk areas. So thanks very much, Sharika. We're going to move on to a colleague of mine, Mo Archery, who has a very interesting picture on his profile on the webinar. It's a lion. So yes, I think it's quite appropriate, Mo. So Mo's a colleague of mine. He's an honorary professor in the School of Medicine and in the School of Clinical Medicine. He's a pediatric infectious disease specialist. He's based mostly at King Edward, the 8th Hospital. He's our go-to colleague in KZN for interesting cases, whether it's query diphtheria or rabies or some other rarer infectious disease. But I think a lot of his work over many years has been on managing HIV children and being a leading light in guidelines. So over to you, Mo. And topic of his presentation this morning is in post-exposure prophylaxis, managing patients who are exposed to potentially rabid animals. Thanks, Mo.
Thanks, Susie. Thank you for the invitation. And I mean, it's always unfortunate, and what we'll do is I'll share some of our experiences in terms of managing rabies, and some of it has been covered in the other talks, but we'll we'll go through many of these issues again in terms of the individual case management. So I'm just going to put my camera on to show that I'm not a lion. So although I am a Leo, yeah, so and lions are not the major cause of rabies. So I think just to highlight, I think the one major thing is that rabies is 100% preventable. Especially again, we've heard about that if we control animal rabies, we can prevent the transmission of the virus to humans. But also, if we manage the animal bites appropriately, we can prevent rabies from happening, especially in that early phase before the virus incubates and enters into the nervous system. And once really it has entered into the nerves and starts migrating into the central nervous system, that is probably too late. There's really no cases of really treatable rabies, especially since once symptoms occur, and there's been a few reported cases, quite controversial with controversial intensive care strategies, but certainly from our setting, all the patients that we've treated, unfortunately, have demise. So it's a 100% fatal condition. So again, I think the highlight is around, at early stages in terms of management of animal bites. So this has, been, highlighted and more recent figures. Again, I think we went through quite a bad patch in 2019, 2020, 2021, where, we had quite high numbers of rabies, and these are the cases in this year. Again, KZN and Eastern Cape have probably the highest number of human rabies cases. And again, to highlight this disproportionate exposure to rabies in terms of age, and really children and adolescents are disproportionately affected by human rabies, and really do represent some degree of risk for having animal bites, and not reporting these bites. So I'll start off with just highlighting this case that occurred during that outbreak. This was a 5-year-old child who presented to our center, lived in informal housing, basic amenities available. Both parents were working. Presented to the outpatient facility, with a history of not passing urine for 24 hours and penile swelling and low abdominal pain. So quite, non-specific symptoms, so really no neurological symptoms. Had been assessed by casualty as having phimosis, and was referred to casualty, and they were saying it was priapism, and was discussed by with urology, P's, and general surgery. And then at the end of the day, they had assessed query UTI or priapism with a query cause. So it was started on colomoxiclav and analgesia, and was kept in the ward. The next day, it was noted to have some inflamed foreskins and some tenderness. Again, was assessed as a cystitis, and again, because things weren't looking completely like a cystitis, was monitored in the ward, and there was a possibility of discharge later in the day. And towards during the progression of the day, she developed some degree of a sore throat, and was complaining of she had pain in the throat, abdominal pain, although had a normal abdominal examination. And again, I think just highlighting that subtle deterioration in terms of the neurological function. By the evening, had started refusing feeds, had developed more overt hydrophobia, was not talking, becoming more anxious and agitated, and developed a spasm of the whole body. And the hypersalivation was noted, and only at that stage, the penny had dropped, and we had suspected that this was a case of rabies. When we had gone back to the family, it was established that the child had been bitten by a dog early in the part of that year, and this was considered to be a grade 3 bite when we went back to that. Apparently, the children were playing, and they hadn't informed the caregivers about the bite, and so hadn't received any vaccination or immunoglobulins, and the status of the dog was unknown. So in terms of management, we're treated as in meningitis and encephalitis with ceftriaxone and acyclovir. We've done the samples and managed the patient in a quite isolated area of the ward, and obviously notified the case while awaiting our results for this patient. So again, I think just to highlight, I think what the case definition is, and again, was has been highlighted. Often when you're making the diagnosis of suspected cases, there's you haven't got a definitive diagnosis, so you can make it based on a clinical diagnosis. So again, acute neurological symptoms that can be, as in encephalitis, which can be either hyperactivity, which is often a lot more easier to make a diagnosis for, but also can be paralytic forms, and that can progress overtly to coma and death, which can be quite difficult to differentiate from a patient with a diffuse encephalitis, where they present with progressive loss of consciousness and not the overt features of a furious rabies. And this is usually, and death usually occurs within 7 to 10 days after the first symptoms, if no ICU care is instituted. And this is, and you'll notify with or without animal exposure. And as highlighted in our case, the presenting features hadn't noted the initial animal exposure. And often those occur in many months before the patient presents with these acute symptoms. A probable case is, again, a suspected case with a likely exposure to a suspected rabid animal. So again, the animal has demised, or there's some evidence of rabies in the animal, either confirmed or not. And a confirmed case is where you've had a laboratory evidence of rabies infection detected in either the saliva, skin biopsy, or CSF as a reverse transcriptase PCR for rabies nucleic acid, or you have rabies antibodies and in the CSF, or on a brain or skin biopsy for the fluorescent immunoglobulins. And then the NICD has this hotline that's a 24-hour service. And again, I think in the hotline is very useful, especially where you are not sure of what to do with the case and how to manage the case and what samples to take. So again, it's a very useful resource in terms of for junior both doctors and nurses and staff who want to get some advice at all hours of the day. So in terms of transmission and pathogenesis, again, we spoke about this. So predominantly in our setting, it's from dog bites, but it can happen from other animal bites, and really it's from exposure, either to scratches from licks, either slaughtering, aerosolization in the laboratory, and person-to-person spray is extremely unlikely. So majority of the cases are really around bites and exposure to mucosa of the infected animal. So the incubation period is really related to the place, how far away the bite is from the central nervous system. So often in children, because children are often much smaller, our kids will present much earlier than adults, and again, if the bite is in the lower limbs, it takes longer for the virus to move up the nervous system into the central nervous system, and actually for the encephalitis to actually present. So normally the incubation period is between 3 and 8 weeks, but may again be shorter or prolonged depending on the immunity of the patient and also the type of bite that happens. So just to highlight, I think once the virus has entered into the tissue from the saliva of the animal, that's actually the golden opportunity in terms of intervention and trying to prevent onwards transmission of the virus, and initially the virus will replicate in the muscle near the bites, and again, that's where we want to instill the immunoglobulin into that local area of the bite to neutralize the virus before it then enters into the peripheral nervous system. And have some immunity, and we're giving the vaccine to boost that immune response, and you have a sustained immune response which will control the virus at the local site and prevent inclusion of the viral particles into the nervous system. And then once it enters into the nervous system, then the virus then ascends into the spinal cord and eventually enters into the brain, and that's when you have the symptoms of encephalitis and the rabies, and sometimes patients will complain of tingling and sensations around the nerves before that. And again, I think to highlight, in the golden opportunity is really in that early phase where we can prevent replication of the virus at the local site, and then onward transmission of the virus. So the clinical presentation, the majority of the cases are these furious rabies. So patients are often nervous, confused, have hallucinations, they have hydrophobia, foaming at the mouth. And this can often be misdiagnosed as anxiety and psychiatric illness. And the progression is over in the course of hours and days. So it has highlighted in the case that we had, often they'll present with quite unusual symptoms and quite non-specific symptoms, and really over the progression, these features become a little more obvious in terms of this being a case of rabies. The more difficult case is really where you have paralytic rabies, which is again about 20% of patients, and they often will be extremely quiet and poorly responsive, and very difficult to differentiate from viral meningoencephalitis. And there is this rapid progression to encephalitis, coma, and death usually within 1 to 6 days from symptom development. So the management, again, the early stages where you don't have a definitive diagnosis being entertained, you need to exclude and treat a meningitis and herpes encephalitis, or viral encephalitis, tetanus, or a drug ingestion, or a psychiatric illness. So ensure that you are covering other possibilities while you're waiting for a diagnosis. Again, I think as highlighted in previous talks, that you do need to take multiple samples. We've had patients who've been in ICU, with features and had been ventilated, and the first sample that was taken was rabies, PCR negative, and really required multiple samples in order to make the diagnosis. So and to take as many samples as possible to ensure you have the make the appropriate diagnosis. You need to attempt to confirm the diagnosis, essentially, from history of animal exposure and laboratory tests in terms of the animal, and obviously you rule it out if the patient gets better, and that's probably a viral encephalitis or another cause, and then the notification process. So this has been highlighted, and I won't go too much into this. Again, your diagnosis is predominantly, when you're suspecting a case based on the history of the presentation and the clinical presentation in terms of the signs and symptoms of the patient and the history of a dog bite. And then laboratory confirmation, again, has been discussed really around taking multiple samples from different era. And then a confirmation of the rabid dog, either antemortem or postmortem. So this is, again, in the NICD guidelines, so that's available on the website. So I'll, it's extremely good resource in terms of, especially guiding your, how to collect the sample, but also in terms of how to submit the sample. So postmortem samples is a brain specimen, and saliva samples, again, at least 500 microliters in a usual clear plastic bottle. And again, you want to get saliva and not sputum, so not a ETA or any other sample, but saliva is the best, and collect at least 3 samples, preferably on separate days, so in 3 consecutive days, not on the same day. And then CSF, again, at least 500 microliters sent to the lab. For nuchal skin biopsy can be done through this punch biopsy, and again, this has been highlighted in terms of how to sample this and send them off. And then these need to be transported in accordance with the guidelines. So again, there's some recommendations in terms of how to package them, and they are sent via your lab directly to the NICD. The specimens need to be kept cool and sent as soon as possible. And all specimens should be labeled and accompanied by the fully completed case history form. So again, just to highlight, this is a separate form. The form, again, is available on the website, so you can download it and print it off the website and complete it. So it gives a lot more details in terms of the type of bite and the prophylaxis or treatment that was provided for the patient. So just to come back to this patient, this patient had a high white cell count, so 23.1. We had done a CSF to rule out a meningitis, and again the protein was relatively normal, the glucose was normal, had a predominance of polymorphs on the CSF, and there was no bacteria found. The HSV, CMV, and varicella was negative on the sample, and we were awaiting the rabies PCR on that CSF. So unfortunately, this child became excessively agitated, restless, again, very distressing for the family and also for for the staff, because these children often come into the facility awake and and they walk into the facility, and the progression in terms of neurological symptoms are quite rapid and deteriorate. It was extremely difficult to monitor, kept removing attachments and IV lines. We had to sedate the child, to ensure that there was some end of life comfort, and unfortunately demised the following day. So I think just to go through the post-exposure prophylaxis, again, the exposure list has been highlighted again. Dogs are our predominant cause of human rabies cases, and that's really because of their close exposure to humans and as pets and as community animals, but other animals, including mongoose, cats, jackals, and cat and goats, can be potential risks. One of the other common areas that we do get calls about is monkey bites, and monkey and baboon bites are extremely uncommon. So there's been no human cases reported from baboon and monkey bites in South Africa. Bats are, again, an uncommon source of human rabies, but have been associated with rabies-related viruses, and so they need to be treated as a Category 3 exposure if there's a bite or scratch if they're from a bat. So the typical symptoms, again, for a dog is that they, excessive aggression, snapping at imaginary objects, and then drooling and wobbling, and then also becoming muscle paralysis towards the end. Similarly with cats, they become excessively aggressive and frothing. Cattle and goats, again, choking and abnormal behavior. And with animals, wild animals, often the features are that they tend to lose their fear of humans. So an excessively friendly wild animal is, again, something we need to be concerned about in terms of animal rabies. So you need to look at unprovoked attacks from any animal, which includes cats, dogs, and any of the other animals listed. And then in areas where rabies is endemic, and certainly KZN and Eastern Cape is one of those major areas where we have a high incidence of animal rabies. So in terms of our post-exposure prophylaxis, so there's, has been highlighted multiple times, there's no blood test to confirm or exclude rabies transmission from animal to human at the time of exposure. So, and that golden opportunity for modifying the outcome is really when that bite happens. So you need to give post-exposure prophylaxis based on the assessment of the type of bite and the exposure, the potential of risk of animal rabies in that animal. So do not delay post-exposure prophylaxis pending laboratory confirmation of the rabies in the animal. And that's, the decision is really based on your risk assessment and no laboratory examination. Again, we often have delayed presentations, and for what it's worth, we still give it even if it's delayed, and if there's unknown vaccination status for the animal. So we, in the algorithm, day 0 is the date of first vaccination. And again, all animal bites are notifiable to the local authority or state veterinary services. And again, around that's about management of the animal and not for to the notification, the NMC program. So all animal bites need to be notified to local authority and veterinary services, but not via the NMC process. So in terms of categorization, so category 1 is really around touching or feeding an animal, licking of an intact skin, and in this case, if there's you need to have no action if the history of exposure is reliable. If the history of exposure is not reliable, then treat as a category 2 bite. For category 2 is nibbling of uncovered skin or superficial scratch without any bleeding. In this case, they will receive the full course of the rabies vaccine, and the rabies immunoglobulin is not required. And for all category 3 exposures, which will be any bite scratches that penetrate the skin or drawing of any blood, licking of mucous membranes, unbroken skins or abrasions, and then also bat bites and scratches would be considered to be a category 3 exposure. And so in these patients, you'll have to give the full course of the rabies vaccination and the rabies immunoglobulin as early as possible into that and surrounding that wound and area of the wound. So general wound management, again, to prevent infections at the site of the wound, you need to flush that wound with soap and water for at least 10 minutes, clean it with the alcohol solution, apply an iodine solution or ointment to that area, avoid or delay suturing where possible, and local anesthetic may aid the spread of the virus. And then we will provide antibiotic to prevent infections at the wound, and the recommended antibiotic is coamoxiclav. In addition to that, you'll give the tetanus vaccination or booster, depending on the patient's vaccination status for tetanus. In terms of the rabies immunoglobulin, so it's all category 3 exposures, and if there's an immunocompromised patient, will need to get your rabies immunoglobulin. So you'll infiltrate the immunoglobulin around the wound as early as possible and at the same time as vaccine administration. And if you don't have it available at your site, you need to source it and administer it ideally within the first 7 days after the first dose of the rabies. So you'll infiltrate the rig in around the wound and give it as much as anatomically possible. So give as much of that dose into the wound and around that wound. Any remainder of that vaccine of the immunoglobulin can be given in the other arm in terms of deltoid area or the anterolateral aspect of the thigh for an infant. And then for category 3 mucosal membrane exposures, you give the full dose of the rig into the deltoid muscle that did not receive the vaccine. So the opposite side is where you're going to give the vaccine. If there's extensive wounds and multiple bites, you can dilute the rig and infiltrate it into that to those multiple areas. For special groups, you give for immunocompromised patients, we give a rig and we give an additional dose of the vaccine. For pregnant and women and children, there's no contraindication to either giving the vaccine or rig. In high-risk prophylaxis, and whether there's rabies vaccine exposure, you provide pre-exposure vaccination comprises 3 doses of the vaccine administered intramuscularly, where you've received previous vaccinations, and then where previously rabies vaccinated individuals, you give 2 booster doses of the vaccine. So just to highlight some concluding remarks, again, I think is really around that children and adolescents have this disproportionate risk of human rabies. So it does highlight the need for appropriate management of animal bites in children and adolescents, and a careful management of that animal bite really prevents transmission of rabies. We do need to engage with communities around community awareness about the importance of vaccination of animals against rabies, but also management of animal bites and appropriate referral to facilities for management of those bites. Unfortunately, human rabies is universally fatal in our setting, and really, the end of the day, it's prevention is better than cure, and really we have strong mechanisms to prevent rabies. So we hope to never see a case of human rabies, and that with adequate animal control and management of human bites, of animal bites, we can prevent cases of human rabies. So I'll thank you there, and I'll stop.
Thanks very much, Mo. Very comprehensive, covered a lot of ground. Just to highlight a couple of issues. In terms of the post-exposure prophylaxis, the proper risk assessment needs to be done. It takes a little time to get histories, but it's absolutely worth it. What we are seeing a lot of is all animal bites are given just vaccine. So those that have been bitten by potentially rabid animals miss out on the rig, and we're overusing resources. So you really have to get a history of, is the animal still alive? What is the health of the animal? Why was the person bitten? And in many cases, because the person was in the wrong place at the wrong time, and the animal is just doing what the animal does. So I think proper histories. Don't be led astray, to use perhaps the dog term, stray dogs, by the history of vaccination in the animal. Sometimes the owners lie because they don't want to get into trouble. The dog may have been vaccinated just a week before as part of an outbreak response, and they were incubating rabies at the time. So that's just a piece of the puzzle, but it's way down on the assessment list. And then, unfortunately, people go on the size of the bite. They look at a bite, it's broken the skin, and they think it's rabies. Well, dogs bite, and there's a break in the skin. You have to look at what is the behavior of the animal, and why did that animal bite that person. Just a couple of words about post-exposure prophylaxis. There are some changes. We don't have a lot of human immunoglobulin. So equine immunoglobulin is being imported. It's a Section 21. It's available in many hospitals and in some clinics in high-risk areas. But if you assess a bite that there's a risk of rabies and there's any size break in the skin, the patient must get rig. It's not just the big bites. And I think you had some 3 very good examples of category 3 exposures. If there's a drop of blood and the animal is ill, animal has died, that patient needs rig. And you may have to refer them. And you need to find it as soon as possible. That will protect the patient from the virus entering the nerve. The vaccine takes 8 to 10 days to work. And before that, the virus is multiplying, happily. Or sadly, and you need to neutralize that virus by getting rig. When we look back on patients who've died of rabies, sometimes they did get the vaccine, but they didn't get rig, or they didn't get it in time. So equine rig is safe. Just remember, it's an equine product. It should be given in a place where if there's an allergic reaction, you can have an adequate response and resuscitation. Despite thousands of doses being given, we have less than half a dozen who've had any anaphylactic response. So it is pretty safe, and it's quite widely available, whereas HRIG is not. The other point is that we're trying to preserve RIG, and where RIG works best is at the bite site. So when you have lots and lots of rig available. In other countries, they use that full dose. But the WHO guidelines have been changed to only giving what is able to be well infiltrated into and around the wound. So you don't have to open all the vials when you start off with that the dosage. And for E-Reg, it's different to H-Reg. Just check your product. And then it's really about eyeballing that wound using good technique, someone who's experienced, and using an insulin syringe and infiltrating thoroughly. But you don't have to give the full dose. So giving it anything that's left over of that full amount per kilo into the muscle is not necessary. It may not even have an effect. So it's local treatment. I think that's really important. And we don't have many cases where proper post-exposure prophylaxis given timelessly has failed. It's really failure to administer PEP, especially RIG, which people don't seem to always consider. And I know it's not always accessible, but then you need to refer the patient. So I think just a couple of points to highlight. And thanks very much for a very comprehensive presentation. And I think always important to illustrate it with a case. I think those are the parts that we always remember. So we're going to move on to our last presentation now. So pleasure to introduce Ntokoza Mapisa. So Ntokoza Mapisa is Head of Communications for KZN Health. He has a background in journalism and nursing and teaching. He's been in communications for a very long time and an absolutely critical person to get the message across to communities and to healthcare workers. So over to you, Ntokoza. Thanks very much. Have some slides.
Thank you very much, colleagues. Can you hear me?
Yes, we can hear you, and I think we're about to see your slides. Thanks a lot.
Yeah, thanks. I'll request Ubabongile Mshongo to run the slides for me. Thank you very much for that introduction, colleagues. Let me start by the introduction and the background of the risk communication and community engagements in the province. In my first slide in introduction, Babongile. Can you move to introduction, Babongile? But
yes, I'm on that introduction. Can you just
okay, I'll just move. On the introduction, we were giving the background that communication helps to build the confidence and explain the rationale for government policies, which leads to people buy-in and easy implementation. Risk communication refers to the exchange of real-time information, advice, and opinions between experts and the people facing threats to their health, economic, social well-being. The ultimate purpose here for this communication strategy is to enable people to take informed decisions to protect themselves. And on Thursday, the 10th of August, 2023, the case of the rabies was confirmed in one of our hospitals at Umlazi. We then quickly resuscitated this risk communication plan to prevent the proliferation of the rabies outbreak, to educate the general public about the risk, symptoms, and prevention practices associated with the rabies, to share the communication strategies, protocols, and tools to strengthen partner communication and coordination. Community engagement plays a crucial role in improving rabies control. That's what we found, that when we engage the people direct in this province, we go an extra mile. One of our main objectives is to place health, well-being, and best interest of the people of this province at the center of all that we do. Our program of action is underpinned by a number of imperatives chief among which is the improvement of people's health status through the creation of a culture of disease prevention, promoting healthy lifestyle, early diseases, screening and testing, as well as improving the quality of healthcare and access there, to mention a few. By raising awareness about the disease, communities can empower individuals to take necessary precautions and seek appropriate care. Engaging communities to build awareness of rabies and vaccinate dogs to prevent human diseases requires close One Health collaboration between the human and veterinary health sectors. I'm on slide 5 now, Mabongile. Communication helps to build confidence and explain rationale for government policies, which leads to people buy-in and easy implementation. That is our background. National and regional elimination plans increases preparedness and surveillance and mobilizes domestic resources. The coordinated response between animal and human health systems not only has a positive impact on the livelihood of the communities, but also strengthens surveillance of rabies and other diseases in the human system. We also have objectives for this strategy. We want to provide the public with timely, accurate, clear information about rabies in a non-partisan way. We want to provide the public with coordinated, well-planned, effective elimination information on rabies that is delivered within budget and is perceived as value for money. We want to make information widely accessible to all citizens with diverse needs, including where possible and within available resources in a language of their choice. In this province, we do have challenges with the issue of language. Most of our people in the rural areas, they've made an appeal to us that in most of our communication, we use English, which they don't easily access, ikakhulukazi ogogo emakhaya and so forth. So that's why we took into cognizance the issue of using the language of the people. We want to build awareness and to ensure that government consult with the public on rabies to build a citizen-centered, client-focused communication system. Over and above that, we wanted to coordinate the communication that ensures that the department institutional entities, partners, and agencies work collaboratively to provide clear and effective communication on rabies to the citizens. We want to establish partnership with a range of stakeholders, including the private sector, academia, research institution, and non-governmental organizations, so as to broaden audience reach. We also want to ensure that everyone at risk for rabies is informed about how to reduce the risk, take personal protective and preventive measures, and go to health facility as soon as possible. We want to debunk rumors and misinformation by providing accurate information on how to recognize symptoms of rabies, how it is transmitted, and what to do to encourage prevention and early treatment seeking behavior. The messages that we are focusing on, we want people to understand what are the rabies. I know that I don't want to bother you with this information because you know better here, but we give more details on what are the rabies, how it can be controlled, how does rabies spread. So that's an information that we are talking with the communities, the dangers of the rabies. We are also having telling them about the common signs and symptoms of the rabies. In all our engagements, we always try. Then the themes and messages, I saw that there is the one that has been shared by national. We will be incorporating it to our provincial one. But in the province, we were saying we are leaving no one behind in trying to grow KwaZulu-Natal together. So in whatever that we do, we push that message as our theme as a province. However, now that we've received the one from national that talks to direct to rabies, we'll incorporate it to our messaging that is here. We've used different communication vehicles to try and communicate with the public. We have a good sense of working with our radios. I'm on slide 14 now. With our radios, we have a program, weekly program, where we connect all our community radio stations, and then we request MEC, the head of department, and some specialists in the department to communicate about any issues that will be affecting us on the ground at that stage. Like in this case, we've had 3 sessions where we were talking on rabies, where the specialist will be invited, and other departments, our sister departments that also deal with rabies, were also invited. So we've had a full-fledged program and community radio stations that dealt with the rabies at this stage. But every time we do it, as we do it on a weekly basis, we ensure that we also talk to it. We also have adverts that are there in all the community radio stations. We pushed the issue of the rabies even on that one. And then we also have the local TV, which is 1KZN TV. That program, the same program that we are pushing on community radio station, it's also used on 1KZN TV. So we have a TV crew that also take that program for TV. And then it's always, every Saturdays, it's always on 1KZN TV. And it's gaining momentum because our people are telling us what they gain a lot of information through that platform. We also have the billboards that are out there. Unfortunately, when we started this, the billboards were already out. But we were also soliciting to find few of them that will talk to the rabies. We also have social media. All our social mediums were buzzing last week with the messages of the rabies, so that our people can consume it. By the way, the program that I'm talking that it's also on TV and radio. We are also broadcasting live on all our social mediums when we are doing it on Friday. So there's also been the community and stakeholder engagements. We had Isibhedlela Kubantu, which is our way of engaging with people. We normally take all the resources and health services that you will find at the hospital. We go to the remote area, we put all those services through our NHI trucks, and people come there in numbers to use those services. So in the past 3 weeks, we've been pushing that. We've been going to the public through that Isibhedlela or a hospital to the people. And then we were talking strong about the rabies and encouraging people to vaccinate their animals. So that has been the strategy so far in terms of the vehicles to communicate with the public on this. There's been a community participation. There's been a communication that is internal through the department, sustainability and continuity. We are keeping the momentum. We keep on throwing the things on social media so that the momentum is on. The community media is involved. Most of our communication platforms, we are activating them. And there is a lot that has been taking place. The program of action on slide 17, we use the KZN Health Chat, the program that I spoke to, as one of our program of action to really talk to the people about it. And there's even call-ins. People were calling in to ask questions about it. And there's a bulk and proactive media buying. With that bulk and media buying, we then used in the past 2 weeks on all our mediums. We used them to sell messages that talks to rabies in all our adverts that are going out there. And as I said, the social media has been there. And then on slide 19 is one of the examples of the media messages that social media messages that we've been pushing in our social mediums. We are ensuring that we use the language of the province. As you can see, that one on slide 19, it is written in isiZulu to explain.
Move the slides, please.
And slide 19.
Babangile, can you move the slides? Can you advance them?
Yes, I'm on slide 19, Prof. Maybe it's the
Thanks a lot.
That's it. As you can see there, that's a message, but it's many of these messages. We keep on pushing them on different dates on the social media. And then obviously we've also issued some statements so that we can use the free space on the media through our current affairs. So we've been engaging the media on this, and they've been interested. We've also targeted some churches. We met with a couple of churches around Umlazi and in some parts of the province. I'm on slide 22 now. Around Umlazi, we've been talking with some different churches, and we went to Shembe Church, the Nazareth Baptist Church, where we were also talking about the issue of rabies and other health-related issues. We also involved Amakosi. Amakosi have been receiving us very well, where we targeted to talk with Amadota, because in rural areas, they use the dogs for hunting and all that. So we went to Amakosi, we spoke to them, and they received this program very well. We've also had community outreach programs, Izimbizo, Sibhedlela Kubantu, Fabulous About Health, where we talk to even LGBTQI people. Ikosombe Lamachita, that's where we target the youth males on Ikosombe, and Isibaya Samadoda is where we target the old men, because sometimes we found that if you deal with these groups, you need to separate them, as others are not free to meet with abantu abancane. They don't communicate freely if you mix them. So there are all these engagements that we had in making sure that people on the ground understand at the community level what is this about. So those are the activities that we did so far, but we continue to learn, and we continue to take other strategies that we found working on the ground to use them, so that people can be aware of rabies in the province. We are saying, working together with our communities, we will defeat Amarabi KwaZulu-Natal. Thank you very much.
Thanks very much. Yeah, we cannot communicate enough about rabies. And yes, just get the message out. We all need to be champions. Okay, so that brings us to the end of the formal presentations. Thank you very much to the speakers for excellent presentations. We've covered a lot of grounds. And now there is time for questions, and the Q&A box is very busy. So I've kind of grouped the questions as best I can. And I have a number of questions, and I'm going to start with Kevin on the veterinary side. So Kevin, if you want to join us,
yes,
I'm going to give all the vet questions to you. And before you start, really, once again, a call out and thank you to the vets, the animal health technicians, those who support campaigns. And I know the environmental health practitioners are very active on the ground, following up patients and really playing a major role in our rabies response. So, Kevin, what's happening in our neighboring countries? I don't know if Alicia's back. I know she went onto another webinar. It's a busy day today. But we do get rabies coming across borders. And I think particularly of Lesotho, perhaps Mozambique, maybe even Swaziland. Can you give us an idea of what's happening there?
I can give you as much information as I have. So we have just recently engaged with Lesotho. We've had a meeting with them to communicate. There is a common border outbreak or a transfer of the disease. And I will say it could go both ways, but we see the disease coming from Lesotho into the Free State, and but not at a significant level. And we're negotiating with them at the moment. So there is that movement. We used to have a infection along the border of Swaziland. People were often blaming Swaziland for this. And what we did is we vaccinated our communities on our side very thoroughly. And the disease disappeared probably 20 years ago. And it hasn't been back. So that was encouraging. And I don't think that there's any introductions at this stage from Swaziland. The Mozambique border, that is a porous border, but it's also in an area where not a lot of sampling is done from our side. It's very remote, far away. So, and we don't see a significant cross-border movement there. We do have cross borders with our neighboring provinces, especially the Eastern Cape. There's a to and fro movement of the disease between KwaZulu-Natal, Eastern Cape. And
Can the person mute? There's somebody coming.
Sorry, somebody
needs to be muted. Sorry, we can hear you.
Please, can you check your audio?
Your mute button. Mr. Ferry put everyone on mute except Kevin and me. Okay, thanks, Kevin.
Okay, so yeah, so there's not a lot of movement between countries. Certainly on our northern border, there is previous sequence work has shown that there have been common outbreaks with our neighboring countries, but there's no significant numbers that we see at this stage. But we are communicating with our neighbors where that's possible. And hopefully we can improve that in the future. But it's not a significant threat to human rabies in South Africa.
Thanks very much. I think the other issue is that people take their dogs on holiday from provinces where there's very little rabies. Obviously, they should all be vaccinated. And then they go to the Eastern Cape, for example, and they get exposed there. So it's a reminder that all dogs and cats in this country have to be vaccinated by law, at least every 3 years. And in high-risk areas, actually the practice is to do it every year. So even if you don't have rabies in your province, just remember it can be imported by an animal that's come in or an animal that's traveled. And then people pick up animals and the side of the road, they think they're cute, and then they bring them home. That's not a good idea. Can you tell us about vaccination in cats and the issue of stray cats? I think it's a concern.
Yeah, I believe this is an important problem, and it's a growing problem without a solution at this stage. So we, as a standard, we vaccinate cats as well as dogs. It is in the regulations to vaccinate cats. But as I think the question alluded to, the fact there's growing stray cat populations, and there's lots of resources. The problem is who deals with those. Any problem animals is generally a municipal function, and municipalities should cater for problem animal control. This is often delegated to the SPCA with relatively small resources. So the state veterinary services don't, as a rule, get involved with a problem animal control. Cats don't seem to play any significant role in spreading the disease within South Africa, but they're very dangerous as a contact for humans. So there's no real answer to this. The SPCA do, and other welfare groups do, cat colony control, but I don't think at the level that's required. And I think this is a problem that's going to increase into the future, and especially with challenges at municipalities. There's no system that can actually manage problem animals. And it's the same with dogs as well. Often, many municipalities don't have any facilities to deal with problem dogs either, stray dogs and so on. Although there's not a massive population of either of these in South Africa, I believe it is going to be a growing problem.
Okay, let's move on, Kevin, to some other species. What about livestock and vaccination of livestock? And then you can also mention jackal and other wild animals. You know, are there any ways to vaccinate them? How effective is the vaccine? Is there any program? Is it being done?
So the vaccination, well, let's just first look at wildlife. So if you can remember the map I showed you, most of South Africa has got wildlife rabies. The Cape and the Northern Cape is bat-eared fox. A black-backed jackal are significant in the Northwest Province, yellow mongoose in the Free State, and there is overlap between some of those provinces and those species. There may be an aardwolf cycle where it moves amongst the aardwolf, but there's not a lot we can do about these. There is some work being done on bait vaccines in jackal. We haven't seen the progress yet where we're going to be, in a short time, going to be influencing that population, but it does show potential. The offshoot of wildlife rabies is very few human contacts, and not often do you see it translating into dog populations and causing big problems in dog populations. So the wildlife problem is relatively small. It's not insignificant because the disease is completely deadly. In the Northwest, it spills over into cattle very frequently, and the Northwest, in each area, depending on how severe the problem is, the state vets will vaccinate cattle in those areas. The vaccines are registered in cattle. They're very effective in cattle in stopping the disease. Generally, we don't see large groups of cattle dying of rabies. It's normally individuals within herds. That does vary in some places. So it's not a massive number of livestock affected by rabies. But, if you've only got 10 cows and you lose 2, that is significant. So the vaccine does work, but the state has resources to try and control the disease in the dog population so that we can stop human deaths. So the vaccine is limited mostly to that. And as a livestock owner, unless the state vet will do it for you for free, you would have to pay for that vaccine yourself.
Okay. And then just a last question to you about the creatures that are not generally associated with rabies transmission, but there are bites commonly reported. So I'm talking about monkeys, and perhaps we should separate monkeys from baboons, where there have been rabies cases, and rodents, people putting food into the mouth of rabbits and dussies and getting too close. I think those are the commonest bites that are actually reported, with a lot of people coming to clinics. And, can you just give us a sense of how you decide if there is a problem with these? And bats, perhaps deal with bats separately.
So any of these animals can have the potential to be able to transmit the disease. It's very rare that we do see anything like that. Monkeys are always blamed for rabies, but we've never diagnosed it as a monkey. And these other animals are mostly victims. Like recently, we had a pet rabbit in Durban with rabies, and it went nuts and it bit all of the people. But generally, these are very noticeable events, and the patients are treated. And from what I know, we haven't had any spillover or any human fatalities from that. And certainly there doesn't seem to be any spread to other animals. They're not the sources of the disease. So it's a relatively minor issue, but it also does highlight the fact that any warm-blooded animal can get this disease. It can pitch up anywhere in South Africa because we have the disease across the entire country, and any bite of any animal is important to get it looked at. I think that's the main message that comes out of it. We won't be able to do anything, and I firmly believe that they're mostly just victims of other cycles of the disease in the country, but not significant. You don't want to meet a rabid baboon. They will literally try and kill you. But again, I think we've only had 2 cases ever in baboons. It's not a significant thing. It's very rare that it spills over and it doesn't spread within the troop. So, yeah, it can pitch up anywhere. That's the message.
I think the issue is with small rodents, domestic or wild rats or mice, is that if they were bitten by a rabid animal, and perhaps they are, they wouldn't survive the physical injury. So there wouldn't be an opportunity, if that animal that bit them was rabid, for the whole cycle to happen, incubate and then transmit. They would probably die.
Yeah, I agree.
They commonly bite particularly children, and particularly where there's food around and where they're frightened. So
Yes.
generally they're not a risk. But just remember, cane rats in the cane fields are quite big, and there
Yes.
have been rabid cane rats. And then people call rats, they use the term interchangeably when they're not sure what it is. And so, I think a little bit of history of what the person was doing. Did they have food? Did they try and pick up the animal and move it away? These little creatures. And then we get lots of calls from bunny farms and zoos where people poke their fingers into cages. And well, obviously the animal's going to bite you. We have tourists in Cape Town who try and feed little dassies in the company gardens, and they get bitten. Why are we surprised? These animals are not rabid. You just shouldn't be, engaging in that sort of activity. So I think histories are very important. And then lastly, Kevin, what about bats? They're quite difficult. They fly into houses. People are frightened of them, so they try and catch them. They're bitten. Often you don't see the actual site of the bite because it's very small. So, what are the circumstances where you really need to be concerned?
Well, I think bats, we don't totally understand what's going on in the bat population, and the virus that circulates amongst the bats also it's a rabies related virus. We don't have the type 1 virus in our bats, which is a good thing, and we don't fully understand even the treatment of that. But the contact with people and bats is relatively rare, and when people do get bitten, generally they also go and get treated, or they're at least going to ask somebody about it, because it's kind of a scary thing to be bitten by a bat. So it's another one of those messages that goes out there. It's an animal that bites for unknown reasons. You have to get it treated. These bites do occur. Don't touch anything you don't know, or you don't know the history of it. That's a strong message that has to go out, especially to the children of KZN. Any other animal that you don't know and there's no supervision of that animal or knowledge of what its status is, just don't touch it. And especially for dogs, that's a real problem for children wanting to touch dogs. And also the important thing is that the smallest bite is probably the most dangerous. We have to follow up on every bite, because it's not normally big bites that kill people. It's the ones that the children don't want to tell their parents about because they might get into trouble. And bat is certainly going to give you a little bite, but it's a big problem. But not in terms of numbers, I don't believe.
Yeah. So somebody reported a donkey with unusual behavior. We've certainly had some rabid donkeys. We've had a couple of rabid horses. But yes, I think it's about the behavior of the animal and why that person was bitten. This morning there was a buffalo bite in Limpopo, but we know that old buffaloes are very grumpy, and you should stay away from them. They're not rabid. They're very grumpy. They've got a thick hide. They wouldn't easily be bitten. And I think it was probably normal behavior in the person approaching them. I don't think that was a rabies risk.
Yeah.
Okay, so let's move on a little bit to communications. So how do you know your social media and communications are having an impact? So in Ntokoza, do you have some sort of follow-up? We obviously can't do tests on people to see what they've learned. How do we know we're having an impact? And I have to say, there's been excellent communications, social media messages that have been shared through the Rabies Advisory Group and other parties, which I think should go out even more, out even further. And we can make these available to you to share more widely. So in Ntokoza, how do we know we're having an impact? You need to unmute if you're still there. All right, I think in the meantime, I'll go on to something else. And then who should be pre-vaccinated? Mo, do you want to say anything? And perhaps I could just add on a few things. And what about boosters? How do we manage those? And are there some groups that we are missing out on? And I can think immediately of those involved with animal welfare. And there are many animal welfare groups, the very big groups, SPCA, who actually do address prevention in their workers. But a lot of animal welfare groups who either can't afford or are not aware that they should be pre-vaccinating. They get handed the problem animals, and they're not pre-vaccinated, they don't recognize it, and then we have potential disasters. So anything about pre-vaccination?
Yeah, so certainly I think in terms of I think there was another question on tetanus as well. So I think in terms of rabies, the recommendation is anyone at a sustained risk of having a animal bite should be offered pre-vaccination. I'm not entirely certain of, I mean, again, whose responsibility it is if it's the individual or who you work for. So certainly I think, for, whether it's the municipality or the Department of Health or, other entities or veterinary services that are providing that sort of care. I mean, ideally, I would assume, and again, I'm not an expert on that field, be able to provide that service to their workers. The other question was around, should there be pre-vaccination for tetanus? So certainly, I think tetanus booster. We do give tetanus vaccine as part of our childhood immunization program. It does give around 5 to 10 years of protection. So we don't routinely give tetanus, boosters as part of the routine pre-vaccination program. But certainly, if you've had a tetanus injection in the prior 10 years, that probably will give you some degree of protection against tetanus. And again, tetanus, because it's it's a spore that's quite slow growing. So the growth is quite slow. So there's not that imperative in terms of where rabies, where the virus is growing at the site of the infiltration in terms of the bite quite quickly, and there's an imperative to get some immunity on board. Whereas in tetanus, there's not that immediate need to get antibody levels up. So I do, and I'm not quite certain about. Yeah.
So thanks very much. I'll just add to that. So the pre-vaccination schedule has been simplified. It's 1 dose on day 0 and 1 dose on day 7. So it's no longer 3 doses. We also have the facility to give it intradermally. So if you give intradermal vaccine, you will save on the dose. You can get, depending on the size of the vial, and we have 2 different vaccines, you can get 2 or 4 people out of the same vial if you are well organized and you kind of line them up. So that's definitely cost-saving, dose-sparing intervention. And I think anybody who's working in animal welfare should be pre-vaccinated. Obviously, vets and animal health technicians, those working, out there where they could be bitten by a stray dog or they're unaware of, what the rabies risk is. I think it's worthwhile. And what pre-vaccination does, it takes away the need to source post-exposure rabies immune globulin should there be an exposure. And that's always the hard part. In fact, they shouldn't be given it, as Mo mentioned. And that's the value. You can also vaccinate whoever you want, people living in remote areas, or, children get bitten and they don't always tell you they were bitten by the mongoose on the farm. But it's a cost issue. For workers, it is the responsibility of the employer if there's a risk of rabies, but it's often not met. And I know for animal health technicians and vets who should be boosted every 2 to 3 years, accessing vaccine and a service to administer is often quite a challenge, but we're not going to discuss that further. So anyone can get it. You know, wildlife, people working in wildlife, people working search and rescue, the bat huggers who go and rescue these bats, the cats ladies who go and befriend these stray cats. Not a bad idea to have pre-exposure vaccination. It does give you protection for a very long time. You should get boosted with 2 vaccines if you are exposed, but you don't need RIG. So I think it's a good thing to do. And remember, the intradermal route saves a lot of money. And I know Kevin has used it extensively within his own veterinary workers. Okay, I think another group that's been mentioned that we need to reach with communications are the pharmacists. They deliver excellent primary health care, and many people will go to their local pharmacist, having sustained a bite or a scratch from an animal, looking for really wound care. So we really need to inform them about rabies, what needs to be done, how to do a simple risk assessment. And unfortunately, in some pharmacies, they just give vaccine because they have it. And those patients are not referred to RIG when they really need to be. So they need to be included in this group. And we've had a lot of information sessions with pharmacists, but I think we really need to do more of those. Any other questions that we haven't addressed? If you want to put up your hand, we can unmute you. I think I've asked the panelists just to go through the Q&A. If you want to find a question. Yeah, accessing RIG is not easy. So we don't have a list of where RIG is available at any time. It's available in most big hospitals in the province, in all provinces. I think much more extensively available in KZN and the Eastern Cape, because in hospitals, but not always in clinics. And you need to, find out where people can get RIG, because we don't want, just vaccine being given. And there's an obvious rabid animal that has attacked somebody, but you can't access it. And I think the communicable disease coordinators for your area are often a good resource to find out where it can be obtained. Remember that post-exposure prophylaxis is free in the public sector. If you go to a private facility, and often they do have RIG and vaccine, there is a cost, which patients can sometimes get assisted with from their medical aids, but not always. So yeah, I think it remains a challenge, but find out where it is. We don't want, we have an ongoing problem of patients who should have got RIG and didn't. And just while I'm on post-exposure prophylaxis, the highest risk for rabies is in facial bites. And if you're working in a clinic and a child, and it's usually a child comes in and they've been bitten on the face, the lip, the head, the scalp, the ear, and it was obviously an animal that they either didn't know, or it's run away, or it was behaving strangely, they must get RIG. And the RIG must be given into the wound. People look at this and go, oh no, it's too painful. Sometimes they have to go to theatre and to deal with the situation, but they must be referred. And facial bites have the shortest incubation time and a very high risk if that wasn't from an animal that was rabid. And the RIG needs to go into the wound with no local, and it's a difficult procedure. So rather refer those patients. So I see a hand up from Tatiba. Do you want to ask your question? Let's have some audience input. We've still got a bit of time. Do you want to unmute Tatiba, Mr. Ferry? Or they can unmute themselves. I did see a hand go up. I might be wrong. No? Tatiba, are you there? Tatiba Yanta? I see your hand is raised still. Are you there?
Let me just see. Okay. I'll let him to talk.
The question from a vet. Tatiba, are you there? We can hear you, sort of. Just unmute yourself, Tatiba. You're still muted.
Yes, I see that. Thanks. I've got that option now. Thanks very much, Prof, and the other panelists, and all the other presenters. My name is Titiba Yanda. I am an animal health technician by profession. I'm based in the Eastern Cape, veterinary services in a unit called Early Warning, under the head office. I've been listening to the presentations, Prof, and now something that comes to my mind, is that I always see a lot in our province in the Eastern Cape. I always see a lot of stray dogs, and obviously each time I see a stray dog, I always think rabies. Now, I just want to ask from colleagues whether on the legislation part or on our current thought processes that are there, are we considering to sort of develop some or inform legislation to make it talk to these stray animals, these stray dogs, because there is a problem. There's a big problem of people wanting to own pets when they are not responsible enough to own those pets, because a responsible pet owner always knows where their pets are. But in this case, it's becoming a common thing, especially if you go through townships in our province and rural villages. You see a lot of stray animals. And if you ask about the ownership, nobody will ever own them at times. Now, how do we try and sort of develop a thought process, perhaps that can inform legislation such that we put such things under control as a means of minimizing the risk of rabies? Thanks so much.
Thanks very much, Titiba. And over to you, Kevin.
Well, it's a big question. And so if you look at municipal guidelines and bylaws, we actually in South Africa have some relatively good bylaws that talk to animals, the importance of ownership and correct handling and confinement of dogs in South Africa. But these guidelines and bylaws are pretty old, and they're unpoliced because there's hardly anywhere where people need to pay a dog license, where people will be fined if their dogs are running around in the street. So despite the fact that there actually being some good bylaws in the country, and which is normally supposed to be enforced by the municipality, it's simply not. How are we going to deal with this is, I don't know. Some of the research that has been done shows that there's not a significant true stray dog population in South Africa where the dogs are simply living on the streets. Most dogs are owned, but they're not confined. So within rural communities, the municipal bylaws often don't apply, and so local laws need to apply there, and so local authorities actually should be involved. But it's going to be a huge job to try and get a national sort of legal system that talks to this. I honestly don't know how we're going to do that. The system is there, but it's not being enforced or by the municipalities because they are mostly broken. I know in places like Nelson Mandela Bay, there's actually a dog control unit, which should be in most cities and places in South Africa. Welfare organizations are normally restricted to suburban areas or cities. They don't operate in rural areas. So there's a big difference between what happens in rural areas and what happens in cities. So I don't know what the problem is. I believe there should be some more research done as a basis for that, to understand how big the problem is, and then the relevant legislation can come out of that. But again, each province probably will have to do that themselves. I don't think it can be a national thing, and then that will be delegated to probably municipal level, and where we would probably find the same problems, where there's no system to enforce it at all. Because with legislation is useless without enforcement. So it's a big question and a difficult one to answer. That's what I've got to say.
Thanks very much. Just a reminder to everyone to mute if they're not speaking on the webinar. There's a little bit of background chat. And then an interesting question from Hugh Rivet-Karnak. Hello, Hugh, good to see you here. Puppies and kittens and rehoming. You know, we have a lot of this happening. How early can you vaccinate, and what should the procedure be for these puppies and kittens? And just a reminder to mute, please. We can still hear you.
So, if I may, thank you, Hugh. It's a good question, but it's also another difficult question. We've written a document about this now, because you've got to understand that any dog that's rescued, you can clean it up and you can vaccinate it. But if it's incubating the disease, which could be extended period, you could be sending that, when you rehome that dog, you could be sending it home to a new home with rabies. And it doesn't happen often, but it does happen. So any welfare organization runs this risk. And we've produced a document now, which hopefully it's being edited now, that speaks to what must you do as a welfare organization when you find a dog. We believe that with animals, we vaccinate them as early as we can, because they often don't get another opportunity to be vaccinated. There's a lot of research to show that the vaccine works even in dogs younger than 3 months. But keeping them in isolation within the welfare organization where they've been rescued for a certain period to be observed, and then when they do get rehomed, they have to go out with a waiver to say it's impossible for us to say that this dog's not incubating rabies. And that's a very difficult point, because that could then impact the ability for organizations to rehome animals. So it is a very dangerous one, especially for incubations. And we do see extended incubations of up to 6 months. So it's not foolproof, but if the organizations follows good steps of collection, isolation, vaccination, observation, we can deal with most of these issues, but it can be a problem.
Okay, thanks very much. Yeah, a difficult issue, but quite a common problem. So just a couple of words in response to some of the vaccine questions, and Mo can add. The vaccines are highly effective and very immunogenic. They are both killed vaccines, so you cannot transmit rabies, and there's a very expensive process to ensure their safety. Adverse events are extremely uncommon. We get occasional reactions to the very small amounts of more unusual antibiotics, and that's very unusual. But they're very immunogenic, and they're very long-lasting, and they're boosterable. So if somebody was vaccinated, and the question on the chat from Tanya is 6 years ago, just give them one booster. If they were vaccinated even 10 years ago and now there's an exposure, they should not get rabies immune globulin, because you will suppress the boosterable vaccine response with your boosters. So they really are excellent vaccines. And I would sort of, how long is long? I would say if they were vaccinated 20 years ago and now there was a rabies risk, just boost them. After that, it's really hard to say, and maybe you're going to have to give reg. It's we don't have lots of information after that period. We try and boost those who have ongoing risks every 2 to 3 years. I don't think there's lots of good evidence to say 2 or 3 years. Doing titers, antibody titers, can be done, but it's an extra sort of step. It's not easily available. You've got to take blood, you've got to send it off. It's another expense. I would just boost every 2 to 3 years. If you've forgotten and it's now 5 or 6 years, just boost with one booster. They really are excellent vaccines. They're just quite expensive. Dog ones are much cheaper. So the key message is vaccinate the dogs, and we'll have less need for the human side. So I think we've come to the end of the Q&A. If there are any other questions, just post them. If I haven't picked them up, I'm really sorry. You can put them in the chat again, and the panelists can try and answer them directly. And it remains for me to thank all the speakers. Really fantastic work, not only on this webinar, but also in your contribution to rabies prevention and control and elimination. So keep the word out there about rabies. Everybody has to become a rabies prevention champion, and keep rabies on the radar. So over to you, Babangila, for some closing words.
Thank you very much, Prof. Firstly, thank you to you for actually moderating this session for us. I think it was really a good session, and even the interaction from the colleagues, you could see on the chat that people were really listening. To the panelists, all the panelists from both departments, colleagues, you were great. The presentations were great. And I think there were a lot of questions that colleagues wanted to check whether the presentations will be shared. Yes, presentations will be shared with all those that registered. Colleagues, we really appreciate Prof. Mo, Kevin, and to the colleagues in the office that also presented, our communications head, Nas from NICD. We really appreciate your participation in this session, and we're hopeful that this can only be a start in strengthening our One Health approach in the country. I have received messages from the colleagues from other provinces, and they are really grateful of this session, and we are really humbled as KZN, and I believe that Wayne, who has also assisted the National Department of Health, Mr. Piri and Charity. Thank you, colleagues, for making this a success. We really do appreciate. In terms of the way forward, I think there were things that are common for all the provinces that we really need to strengthen. But one thing that I want to highlight is the fact that the issue of stray dogs, it remains a challenge for all the provinces. And I think we really need to strengthen that communication with our municipalities, because at the end of the day, it's sitting on their tables. We'll really need to strengthen their regulation in terms of the bylaws of the stray dogs. It is really a problem. One of our deaths that occurred in July, August, the 5-year-old was bitten by a stray dog. So stray dogs remain a huge challenge for us in the provinces and for other provinces. We really need to strengthen the collaboration using One Health approach. I think this was just the beginning for us, and we can only strengthen this kind of collaboration and ensure that we really reach all those communities, not only at this level, even at a district level. There are vet officers, there are district offices. In KZN, we have CDC coordinators in each and every district. And we are really persuading colleagues to strengthen the collaborations in ensuring that they are sending one message to our communities. And in terms of awareness, really, we need to strengthen social media messages. We need to push those messages to our social media platforms, because we know that people are not more meeting in halls, in shops. People are sitting at home or they are sitting in their offices, but most of the time they spend their time with their phones. So we need to really explore social media platforms and ensure that we are really suffocating them with messages that will ensure that we really get what we want. And as KZN, I think we're still making that commitment to say that we'll remain treating every dog bite we will continue following every dog bite and ensure that people get all the vaccines, because we know that whenever they get one vaccine and the wound is healed, they never come back. So to the colleagues at facilities, we really need to continue following them up. And I've seen that even our private hospitals, they are sending us the kind of statistics of their dog bites, so that we can really assist in also in following up those people. The in-service training colleagues, we need to continue in-service training our healthcare workers, especially on case management. When Prof was talking about the issue of the facial bites, we have been having a thought in the office that maybe what we need to do, whether it's a circular or that can be sent to all facilities, to say that in terms of triaging, we need really to triage those people that will have facial bites. They need the category 1, they need really to be fast-tracked so that they get the required attention timely. And I think the last one, Prof, you have highlighted an important issue that we need to engage pharmacists about the rabies, so that really, because most of our communities, their first point of call when they've been bitten by dogs, they would go to a local pharmacy. So we really need to strengthen our communication and sharing information with our pharmacists, so that they can really be aware of what is it that needs to be done in those cases. In those words, colleagues, in Zulu city, izandla zidlule ekhanda. That is the way of saying thank you very much. I think we have come to an end of this session. Thank you very much, colleagues.
Thanks you very much, Babangile. Very wise words, and thank you for organizing. And special thanks to Mr. Ferry, who was at the controls. I'm going to clone you, Mr. Ferry. You're a wonderful IT person. Thanks very much, everybody, and spread the word about rabies prevention. Thank you.
Thank you, everyone.